welcome in to all the viewers. My name is Michael Mariscalco, and I'm an orthopedic surgeon specializing in shoulder and knee surgery here at OrthoVirginia in Richmond, Virginia, at our Westchester location. And the topic for today is current trends in shoulder arthroplasty. So thank you for joining us. And the topic involves glenohumeral osteoarthritis. These two pictures that we're looking at here on the left side of the screen is a picture of cartilage wear of the ball. And when cartilage breaks down, by definition, that is what osteoarthritis is. The picture on the right is a picture, an x-ray, actually two x-rays, a frontal view and a side view that show what an arthritic shoulder joint looks like radiographically. Next slide. So the prevalence of glenohumeral osteoarthritis, abbreviated OA, is 16 to 20% of middle-aged to elderly adults. There are multiple risk factors: advanced age, female sex, elevated BMI, smoking, prior traumatic injury, such as instability, which would be a dislocation event that typically happens earlier in one's life, and/or repetitive occupational use. So there are multiple risk factors that can predispose someone to the development of this. I think one that's not listed is genetic basis. Some of these are heritable. So next slide, please. So the symptoms of osteoarthritis in the shoulder are severe pain, global or generalized stiffness, grinding, popping, mechanical type symptoms. And oftentimes what brings people in to have this evaluated is sleep disruption. Severe pain at night is a common complaint with shoulder-related problems. Next slide, please. So there's been a classification system for this condition, which we won't go into all the details, but I think this slide is helpful to point out that this is a ball and socket joint, and that over time, this arthritis problem can cause a wear pattern asymmetrically to the socket. And there are different categories of this, but I think it is pertinent and part of this discussion to understand that as this problem progresses, the wear pattern, not only of the cartilage, but of the bone, primarily on the socket side, can become problematic when one is considering procedures to fix the underlying problem. Next slide, please. So who would be a optimal surgical candidate? Typically, it's those that have had persistent pain, sometimes can be years or decades. Many people have tried conservative treatment, such as anti-inflammatory medications, physical therapy, multiple cortisone injections, significant loss of range of motion that limits one's ability to use their shoulder for activities of daily living, deformity of the glenoid, the technical term for the socket, as we saw in the slide before. There can be variations of that deformity. And then a question that I often ask patients is, how much does the problem affect their quality of life? So these are all considerations to be looked at for who's an optimal surgical candidate. Next slide, please. So there are three main types of replacements, and I'd like to go through three of them. The first being a hemiarthroplasty or partial replacement. The second being an anatomic total shoulder replacement. And anatomic simply means replacing it in the native configuration that the human body was designed. And then the reverse total shoulder replacement is where you're switching the position of the ball and the socket And we will get into the reason for that here shortly. Next slide, please. So hemiarthroplasty or partial shoulder replacement indications. Avascular necrosis is when the blood supply to the ball gets disrupted, and this picture on the right shows the head of the ball being no longer spherical. So when the head loses its sphericity, it collapses, and this is an X-ray of an advanced type of avascular necrosis. Humeral head fracture, fracture and break are synonyms. So, someone who sustains a trauma to the shoulder could be considered a candidate for this. Shoulder osteoarthritis in young patients under 55 may be a candidate, especially younger patients that perform heavy repetitive lifting at work may be better suited for a partial replacement versus a anatomic total shoulder replacement. And we'll see why here in the next few slides. Next slide, please. So hemiarthroplasty or partial shoulder replacement has evolved, and we'll see this evolution as we move through this presentation. But, generally, I would say over the last decade, shoulder implants have improved substantially, not only in their design, also their materials, their ingrowth surface, and overall ability to correct deformity. This would be one of the newer designs. It's a FDA-approved pyrocarbon head surface that was approved in 2022. It has a graphite core with a pyrolytic carbon coating, and it has substantially lower wear rates on bone compared to traditional cobalt chrome, and the cobalt chrome material is shown in the bottom right compared to the new material in the top image. So I think these newer surfaces and materials have allowed us to present options to patients, certainly that weren't available over a decade ago, and that can likely make it a better long-term option in the right indication. Next slide, please. So this is an X-ray picture of a partial replacement, which indicates the replacement only of the humeral head surface. And as it currently stands, it has to be used on a small stem that goes in the humeral canal. And I can actually show you a three-dimensional image of a similar stem if you want to flip this. So essentially what it is the material goes inside the humeral canal and is typically press fit into the bone. And then the implant sits, the new head would sit over top, and it is mated with the actual stem, which usually has typically a piece that unites the two together. So that is sort of a three-dimensional look with a sample that I brought in. And this hemiarthroplasty does not address anything on the glenoid or socket side. So that side is left alone, hence the term hemi or partial replacement. Next slide, please. An anatomic total shoulder replacement is where the ball and the socket are replaced in the same manner as the shoulder was inherently designed in the human body. It requires an intact rotator cuff to function, and I can actually show you a quick image on that here. So the rotator cuff tendon is a group of 4 tendons around the shoulder. It encompasses or goes above the actual ball, which you can't really see in this three-dimensional image here. And so it is really important, and kind of the main differentiating feature is that the tendon in its entirety, in most cases, needs to be intact for the anatomic replacement to function correctly. And the resurfacing on the socket side is a polyethylene sort of, and you can flip over for a second if you can. It's a smoothly polished polyethylene surface, and there are different types of these. Different companies make a variation of something similar, but that becomes the new socket. And so the joint then is an anatomic or ball and socket design as the shoulder was normally designed. Next slide, please. So planning of shoulder replacement procedures has also come a long way over the last decade plus, probably even more so over the last 5 to 7 years, in that a CAT scan can be used preoperatively to assess the overall alignment of the shoulder, primarily focused on the glenoid or socket side, as you can see on the left. And what that allows the surgeon to do is to preoperatively plan cases, especially those with substantial deformity. The picture on the right shows some preoperative planning software in that you can superimpose the position of the implant into the patient's own CT scan. It would be analogous to having a preoperative game plan for those sports enthusiasts out there, or simply being able to look at implant position before even entering the operating room. So this has been a very important feature in getting the implant position correct at time zero, which definitely has an impact on overall function postoperatively. And I'll show you a sample if you wouldn't mind flipping over. So this is a sample of a patient's CT scan, and what this technology is able to do is manufacture a guide that fits over their native glenoid or socket that then you can use at the time of surgery to pinpoint the center part of the socket. And so again, it's very useful in deformity cases because at the time of surgery, it can be technically challenging to really truly identify the center. And so relying on preoperative CT imaging has been very beneficial and improved overall accuracy and patient outcome. Next slide, please. So different designs of these replacements, some of these newer options are going stemless, which essentially what that does on the humeral side, it removes the stem feature for the actual implant. So instead of relying on the stem, you're relying on a much smaller housing, I guess, if you will, to hold the head in position on the humerus. And these stemless designs have evolved to be able to convert anatomic replacements to reverse replacements, and they're working on final approval of that. The picture on the top right kind of gives one an image of what that would look like. And then the picture in the middle here, I think, is important to take a look at for a minute. So the socket of the ball and socket, otherwise known as the glenoid, as I showed in one of those earlier slides, can develop considerable deformity to it. And being able to correct that deformity previously was a major challenge at the time of surgery. There are augmented glenoid or socket components that have built-in corrections that CAT scan software can help plan and account for at the time of surgery. So if there is substantial deformity, it is very beneficial for the surgeon to know that ahead of time and plan, and then potentially use one of these augmented glenoid components to correct that deformity at the time of surgery. Next slide, please. So these are several pictures of a stemless humeral or a stemless anatomic shoulder replacement. I think one Main feature is it's a bone conserving option. Traditionally, as several of the prior images have shown, these used to require a long stemmed component down the humeral shaft. With this newer design, that obviates the need for having to use that. And so I think not having to actually put a long stem in the shaft, if the bone quality is sufficient along the head region, I think that is a beneficial thing to consider. And as I showed earlier, these newer designs allow for adaptability, as we'll see on the next slide. So when performing an anatomic replacement, as in the pictures in A and B, it is, I think, wise for the surgeon to consider revision situations down the road, as in if for some reason the implant were to fail or to have a problem, as in the rotator cuff tearing or wear of the actual glenoid or other reasons, having the ability to convert it from option A to option C, for example, or option B to option D, I think gives the surgeon more flexibility and not having to really do anything on the humerus side, and mainly focusing on the socket side. So the adaptability and modularity of these new components has been really impactful for shoulder surgeons that do this type of surgery. Next slide. So what happens if the rotator cuff tendon is acutely or chronically torn and there's arthritis of the ball and socket joint? And this is a common scenario, one we're starting to see more and more. And we will see kind of an end stage example of this next slide. So essentially what happens as that problem progresses is that the ball or the head of the humerus starts to migrate superiorly through the rotator cuff tear or defect, and it decreases patients' ability to raise their arm above head level. And this is a advanced example of that. Sometimes it's so severe that it's been described as being pseudo-paralytic, or not paralyzed in the sense that the motor function is not working, but the ball cannot rotate on the socket because there's no humeral head depressor effect from the rotator cuff. And so this is where the reverse shoulder replacement has really been a big evolution in the ability to help these patients improve their overall function post-operatively. Next slide, please. So this is an example of an X-ray of what it looks like. And essentially what it is repositioning or changing the position of the ball on the socket, or positioning the ball on the socket side and the socket on the ball side. And what it allows for is the deltoid muscle, that's the big muscle on the side of the shoulder, to be the primary mover of the shoulder. And so again, designed for patients that have chronic rotator cuff tears with arthritis, although there's been some recent studies looking at even using it for some patients that have severe osteoarthritis, possibly with significant deformity of the socket that you cannot correct with a normal polyethylene implant that we had looked at previously. Next slide, please. So what are the options for patients that have severe deformity of the socket that you can't correct with implants that are currently available? And those implants come in usually a half wedge or a full wedge design. This is a picture showing you a preoperative CT scan with a plan that is a custom base plate. And the base plate is what houses the sphere. The sphere they call it the glenosphere. So the glenoid side of a reverse replacement can be planned using preoperative CT imaging, and a base plate can be custom manufactured. It traditionally took 6 or 8 weeks, now is shortened in some cases to 4 weeks, but it will match, it's like a key, it will match the native anatomy of the shoulder, and it can be used at the time, and the design for it would be used at the time of surgery to match and correct the underlying deformity. So CAT scanning preoperatively is extremely beneficial in these complex cases. They're actually being able to use it now more even for revision cases. But I think taking advantage of this type of technology has helped surgeons improve patient outcomes. Next slide, please. So these are some of the common questions following any one of the 3 types of replacements that we covered. They can be performed as an outpatient. So patients can, in some situations, come and go the same day. It is a general anesthetic, typically done under a preoperative interscalene nerve blocks. Some of these nerve blocks can last for up to 48 to 72 hours, which can provide considerable pain relief and decrease opioid requirements. Usually it involves a sling for 6 weeks to allow an anatomic replacement, and hemiarthroplasty cases to allow the rotator cuff tendon to heal to the implant. Patients can loosen the sling at rest for hand, wrist, and elbow range of motion. Outpatient physical therapy starts within the first week. It is a structured rehab program. I tell and remind patients they need to be a good rule follower for the first usually 3 months to have an optimal outcome. For example, there's no internal rotation or pushing up from a chair with the operative arm for upwards of 8 to 12 weeks, and that is to minimize risk of dislocation. Again, it's a ball and socket joint, so that would be just one example of what the therapists reinforce and why they go to the lengths that they go to structure these therapy programs the way that they're structured. And the overall recovery being at the earliest 3 months, but patients can make progress for up to 6 months or even longer. I would say that after about 1 year, 12 months, most patients would say they plateaued from an overall recovery standpoint. But those are some of the common questions and things that I review preoperatively with patients. Next slide, please. So I wanted to thank you again for joining us on this talk and current trends in shoulder arthroplasty. And I'd be happy to answer any questions that you may have.
Thank you so much. So we will be answering questions submitted earlier and questions submitted live.
Okay.
Not all questions will be able to be answered, but we will get through what we can. Our first question is, how does someone know it's time for a shoulder replacement?
Yeah, that's a great question. I would say that, shoulder-related problems like this typically present later than the knee or hip because it's a non-weight-bearing joint. And so radiographically, on X-ray at least, the problem is much more advanced when I see it for the first time. Typically, it's based on overall pain, functional limitation, grinding, mechanical symptoms, loss of sleep. It's more of a function or limitations in patients' lives or activities of daily living. And, ultimately it comes down to, how much does it affect someone's quality of life? Is it, are they able to partake in the things they want to do and hobbies, activities, or is it, does it just, typically pain is the number one thing that brings people in, but does it just affect them too much or have reached a point where they need to be evaluated?
Thank you. How does the doctor decide between doing the anatomic and the reverse total shoulder replacement?
Yeah, so the simple answer to that is if it's determined either historically, clinical exam, X-ray, CT imaging, MRI imaging, a combination of factors that the rotator cuff tendon is not intact, or it's clear they have a large to massive chronic tear, an anatomic total shoulder replacement will not function well in that scenario. So those particular patients are excluded. Now, if the rotator cuff is intact, then it becomes a little more difficult to answer that. It's usually based on glenoid deformity, patient expectations, other factors go into that, and that's a discussion we'd have in the office. An anatomic replacement, typically will give you a little better range of motion in a similar setting compared to a reverse. So it does, it does get a little tougher to make that final decision, but I do have a conversation with patients in the office about that. But the main determinant is status of the rotator cuff tendon.
Thank you. How long does a shoulder replacement last? Does the type of shoulder replacement matter in how long it lasts?
So an anatomic total shoulder replacement, and there's long-term data on this. I mean, at 10 years, 90% of patients should still have a functional replacement. At 20 years, I think the numbers approaches 75 to 80%. So, I mean, the long-term outcome studies are good. I think it's important to assess, patients' overall activity level prior to surgery, what their expectations are. And then I think carefully examining their imaging is important, assessing deformity, trying to correct anatomy. And there are a lot of factors that go into this. I will say the materials in the implants, as we went through during the talk, have gotten better. And even in the reverse replacement scenario, the materials and bone ingrowth on both the humeral and base plate side, again, have come a long way. So the body, the bone ingrows into these implants in a way that I think is better than it was historically. And plus, with the ability to correct deformity and have the best fixation at time zero, reverse replacements can do extremely well long-term. So that would be my answer to that.
Thank you. You mentioned not pushing off with the operative arm while you're healing, but are there any long-term restrictions after a shoulder replacement?
After an anatomic shoulder replacement, I tell patients to be a little careful with heavy flat bench press, push-ups, military press, loading of the shoulder, if it's done repetitively, is concerning, so younger patients that have severe shoulder osteoarthritis that maybe have a job that they're doing the same activity for 8 to 10 hours a day, like that repetitive loading, mechanical stress on the joint can cause glenoid loosening. So I think it does depend on activity level and what one's demands are. After a reverse shoulder replacement, I would caution people for the first 3 to 4 months not to overload the implant. So I would tell people a 5-pound lifting restriction typically. It is a different implant that puts different stressors on the shoulder and scapula. So their patients need to be careful that they're not overloading a reverse replacement, at least for the first 3 to 6 months, to minimize risk of an acromial or scapular spine stress fracture. So, typically after that stage, the risks or restrictions, it's certainly, have to keep those things in mind that I mentioned earlier, but less concerning the further one gets out, especially from a reverse replacement standpoint.
Thank you very much. That is all the time that we have for today. Dr. Mariscalco, would you like to close?
Yeah, but thank you so much for joining in on this session. And hopefully I shed a little light on some of the newer trends in shoulder replacement. And I appreciate your time. Have a good rest of the day.